Hello everyone. Today I would like to share a very interesting and a rare condition, that's median arcuate ligament syndrome. And I'm well versed that most of you will feel that this condition doesn't require surgery many times. Yes, it's true. It's a condition which is diagnosed by radiologists on CT scans for patients who have abdominal pain, and many of these patients do not have classical symptoms. It's incidentally picked up in couple of patients. But this patient which I'm going to share, he was a young boy, 20-year-old, who presented with intractable pain in the upper abdomen lasting for almost 2 years, and he had required hospitalization for this pain 3 to 4 times. So his clinical examination was normal, and the pain was always associated with vomiting and nausea. He had decreased intake because of pain and had lost couple of kgs weight. He had normal BMI. The blood workup and upper GI endoscopy was bang normal. He had presented to me with a CT scan which was suggestive of classical median arcuate ligament syndrome. We reviewed the CT scan, which showed the classical hook sign, which differentiates it from the atherosclerosis of the celiac artery. Also, he was young, so there was no concern of atherosclerosis. And it shows compression of the origin of celiac artery, as you can see in the CT scan, with post-stenotic dilatation. And that's the typical feature of classical hook sign. So after this CT scan, still I wanted to be sure that he has this condition. So asked for a color Doppler, which demonstrated the presence of increased flow velocities in the celiac trunk. So then the patient was thought for a surgical intervention, and hence we had a thorough discussion. MDM was conducted between the team as well as the patient's relatives and the gastroenterologist. And in view of multiple episodes of recurring pain, we offered him surgery of median arcuate ligament prenis. So we did a diagnostic laparoscopy first. There was nothing else found, and these were the port placements: 3 5mm ports, 2 in the mid-clavicular line, either mid-clavicular line for dissection, and 1 in the left flank for stomach retraction. So after the first port was placed, camera port, we put Nathanson's retractor for liver retraction. You can see the liver is quite normal, and that's the stomach. So the trick here is, once you reach the lesser curve, you dissect in the lesser curve and identify the left gastric vessels. So this is the opening of the pars flaccida, and that's the left gastric vein which is identified here. The artery will be beneath it. So all the tissue around the celiac trunk has to be dissected. The surgical therapy involves either removal of the nerve plexus around the celiac trunk, dissection of the celiac artery completely, that is called celiac ganglionorectomy, celiac artery decompression, or reconstruction and stenting if it is too narrowed. So these are the multiple options available for therapy for median arcuate ligament. In this patient, we underwent celiac artery decompression, and we excised the neurological tissue along the celiac trunk. So this is the dissection on the crura. So in this step, one has to be careful and identify each branches. You can see here left gastric vein. So we are lifting it up and dissecting the right crural fibers. All the fibrofatty tissue adjacent to the vessels is excised. We also encountered 2-3 lymph nodes in this area. They were reactive, and we excised them too. So this is again additional lymph node on the superior border of the lesser curvature of stomach. So we send this for histopathology. They were reactive. And now dissecting the crural fibers to identify the aorta and to go to the origin of the celiac. So all this tough fibrotic tissue was excised, initially incised with ultrasonic scissors. One can use either ligosure or ultrasonic. So creating the plane and then dissecting the tissue. So there will be one step where one feels the give way, the taut structure which was compressing on the aorta and the celiac trunk. So at this stage, we are still dissecting above the aorta, and now this is the tough structure which is being dissected. So that's the left gastric vessel. These are the crural fibers which were on the aorta. We also gave ICG to this patient on table for delineation of the anatomical structures. So we are splitting the diaphragmatic rural fibers and identifying the aorta. Basically, it's the aortic aperture from the diaphragm, from where the aorta passes, and that diaphragmatic muscles impinge on the celiac trunk, and that causes the ischemic pain which the patient suffers. So now here is the left gastric again being dissected, and all the tissues around the vessels are being made bare. And this is a tough structure which is dissected with the Maryland, and now with the ultrasonic scissors, and we are cutting the tight ligament. Once this is released, you will see the vessels which are pulsation in a very, very nice manner. So for additional traction, we just took a vessel loop and hooked it, and now you can see the ICG image. So that's the tough structure which we had to release it properly. Yeah, you can see the give way. It should be incised completely. The whole vessel should be made bare, and then all the tissue, neurological tissue adjacent to the vessels are excised. So the trifurcation is seen properly. That's the splenic artery. Inferior is the common hepatic artery to the right side, and above is the left gastric. So all three branches are seen very clearly. Opening of the branches also should be very made free. It should not be that only the ligament is incised. And then the Thunsen's was removed. The patient's blood loss was minimal. As you can see, it was a clean surgery. Duration of the surgery was 120 minutes. Post-op was very, very uneventful and rewarding. He was started on liquid diet and discharged on day 2. Unfortunately, he presented back with pain in the abdomen, and literature also shows that some patients do have recurring pain. So this has to be explained to the patient on pre-operative counseling. Fortunately, it settled with antacids, and also in some patients one has to rule out a psychiatric disorder prior to surgery. They have autodystonia that has to be ruled out. So in this patient also, he had undergone a psychiatric evaluation prior to surgery. No other cause of pain was found, and at 2 years follow-up now, he is comfortable, asymptomatic, though there is not much weight gain, but there is no further weight loss, and the typical postprandial pain which he was experiencing for the past 2 years has gone away. So it's been 2 years follow-up, and then hence the presentation. I thank my team. Dr. Shailesh was the anesthetist, and my surgical team, Dr. Prashant Salvi and Dr. Kanchan Sachanandani, both are accomplished surgeons. And Dr. Virashri Bhire was our RMO who helped the pre-op management. Aarti Vadkar is our physician assistant who helped in making the PowerPoint presentation and the video editing. And Dr. Nitin Naramne was a gastroenterologist who had done the endoscopy also and part of the team. So thank you everyone for patient listening. I would appreciate comments and criticism if any on the group. Thank you very much.